So now we invite our next faculty, that Dr. DEEPAK MISHRA. He is a associate professor in BHU, and he will be speaking on clinical diagnosis and DD. So this is very important to differentiate between TAS and the endophthalmitis. And one thing I advise, even if you in doubt, always treat it as a endophthalmitis. So Dr. DEEPAK MISHRA, he is the chairman scientific committee of UP, and also the very active member and the convener of SSTC, where we are giving the training of surgical skill transfer course. DEEPAK MISHRA.
Thank you, sir, for the wonderful introduction, and thank you, Dr. Chaudhary, for involving me in this IC, which is very much important for everyone, from resident, from general practitioner, from institutional people. What we usually fear is only one of the disease that is much more for all cataract surgeon, non-cataract surgeon, is endophthalmitis. It is something which even the names fears most of the ophthalmologists, that no one like to hear this name in his or her case. So with these notes, there is no financial interest. I will start. What are the common reasons are the things which we have to diagnose or differentiate when we suspect a case of endophthalmitis? There are many, but my topic is only related to the TAS, which is much similar and associated with endophthalmitis. Other reasons in these cases are lens-induced uveitis, inflammation left out sometimes by some cortical matter or something else. It may be looks like in cases of masquerade syndrome and vitreous hemorrhage, but we will discuss our talk in differentiation between endophthalmitis and TAS, which is very much important. Now coming to the TAS. TAS is something which is the term coined by Munson in 1982, and it is something a sterile kind of inflammation. It is not truly the true inflammation, and it usually we see because of that some toxic effects, not of the infective etiology. And what are the potential causes for the TAS is something which is related with sterilization or some medication or intraocular things, drops and ointment. There are many causes, but we have to only concentrate on the first one. And this endophthalmitis is having different etiology. Either it is bacterial, viral or fungal, but it is, we can say at present that TAS is of non-infective etiology and endop is of infective etiology. And based on that, endophthalmitis is divided into different types, whether it is endogenous or exogenous, acute or delayed. This classification we all know. I am skipping this. But TAS and endop, again, what is the problem? Problem is that both can appear almost in early endop and the TAS at the same time set, means after the same duration, but treatment is not same, etiology is not same. Clinical features mimics with each other, but how to treat this and what is the difference between etiology is separate. So with these two conditions, this is a simple chart we can tell you. Even the TAS, the onset is within 48 hours and endophthalmitis is usually 4 to 7 days. Sometimes later on, a delayed endophthalmitis can occur after 4 weeks or 3 weeks of fungal or another etiology. But one is important difference is onset. Another one is the pain. In the TAS, patient usually didn't complain of any pain or mild diffuse pain, but in case of endophthalmitis, pain is more. Then you have seen the discharge and lid reaction. Lid reaction is something which is obviously seen by some expert that yes, in case of endop, it is more. And when we compare the anterior chamber, then anterior chamber reaction is usually less in endop but more in TAS. And this is something feature which is very much important, and everyone can know the corneal edema. It is I can say what are the differentiating factors clinically. This is we can see most important and usually found in all that. In case of TAS, you have seen here complete limbus to limbus edema, and in case of endophthalmitis, it is either localized or segmental, but usually the cornea, you can see something from the through the cornea. But in case of TAS, it is usually difficult, and you have seen this is the something feature which is differentiated between both. Coming to the IOP, IOP may be normal in both cases, but usually in TAS, it may be of higher side and endop of the lower side. And vitreous, again, if you are able to see the fundus, then it is a clear-cut indication that in case of TAS, vitreous is clear, and whenever is endophthalmitis, there is vitritis or vitreous hemorrhage. So I suggest at least these two features, limbus to limbal corneal edema and vitritis, these two are the important thing which we have to differentiate, and usually these two can differentiate both features easily. Another thing difference, whatever we can do in the management, I am not going in detail, just giving some silent point that whenever is the endophthalmitis, you have to take an extensive and aggressive treatment for intravitreal and topical antibiotics, and whatever the guidelines of endophthalmitis vitreous study, you can go through. But in case of TAS, always rule out what is the infection. Never treat or say that it looks like TAS, so I will not go for that. Until unless you rule out the infection by culture sensitivity or whatever the method, always, as Dr. Mathur sir suggests, if there is a doubt, you always have a fear, or since endophthalmitis is more dangerous, so think of the more dangerous thing, but you can monitor it and closely. With this, just a take-home message, we have to see what is the time of the onset, corneal edema, anterior chamber reaction, and vitreous or vitritis. These 3-4 important features can help you in diagnosing these two clinical cases. With this note, I would like to thank you.